Hey, Tim, thank you for coming in. I mean, you have just an amazing background, definitely a prominent figure in health information technology. You've been at this space for a long, long time in digital transformation, data analytics, and so on. And then also just really doing just incredible work in shared services and so on, and particularly in health. So thank you for coming in and sharing your insights with our audience.
Thank you. I'm excited to be here.
So, Tim, you've got this, as I mentioned, remarkable career. You're definitely a leader globally, and particularly in the US. There's got to be the inflection points in your life that created this wonderful career you have, both professionally and personally. And it could have been something when you were 3 or 5. It could have been something later in college, in school, a mentor. What were those magic moments that really shaped you and who you are today and who you are going forward?
Probably the first thing was I took my cousin for a ride on a snowmobile, and I was a little bit more wild than he was when I was about 8 years old. So probably a little young to be driving in modern day anyway. But he fell off the back, and he got his arm caught in the track when he was sort of trying to reach back in. And um, not only did I kind of have this immediate, wow, there are consequences to doing things. But for the next handful of years, he was in and out of the hospital. He had a whole bunch of different experiences with the healthcare system, and it was traumatic on his family. It was traumatic on my family because it happened, to my dad's brother, as children, and we got to interact with the healthcare system in a very, very different way. And so that process and watching my cousin go through that really impacted my whole commitment to sort of healthcare. But at the same time, I didn't really understand that that was going to be one of the very personal reasons where I was going to be interested in fixing and changing this whole industry for people. Um, the other big inflection point was a physician who dragged me out of the College of Engineering to kind of give him some help, um, putting in a data network for an academic medical center. And he knew a lot more about what I was going to do than I did. But he pulled me in to try to connect all the different silos across the healthcare system. And they had a grant from the National Library of Medicine, and I raised my hand because I was a young technologist, and I said, sure, it'll be no problem to move a bunch of people 15 miles away. No problem at all to do that and connect them with data networks. And that experience turned out to be really both full of technical challenges, but organizational challenges. And I got a real taste of what it takes to accomplish things with technology and systems of people. And that I was hooked. I was hooked on the complexity. I was hooked on the technology. I was hooked on the fact that we could do those kinds of things, and it profoundly changed the way organizations and people interacted. But keeping in mind that there still are always consequences to what we do with those things, and that plus the final thing of a couple of professors grabbing me and saying, "Hey, you need to get a doctorate, even though you're late in career," and the support that they gave me to sort of say, "Hey, take the time to sort of get this extra credential and sort of broaden your horizons beyond the sort of technology space. Um, understand health policy, understand the bigger picture." Uh, Really pivoted me in the space that I'm in today.
So that's really, interesting. It's young experience of somebody having medical challenge and just seeing on the user side what that is like. And it gave you some deep insights and maybe some challenges in the system. And then having the opportunity to do some transformation and realizing, wow, this is really quite difficult, even though it's a technical issue, but it was also medical and sort of the human resources aspect and administration aspect. And then being pulled by people to sort of mentor you to getting your master's degree in health administration and a doctorate in health administration from Central Michigan University, even though your background initially was in engineering and science, but then you're combining data science and informatics and computation with health in general. And it's a growing field. So can you sort of give me your career arcs then? So you have these inflection points in your life that help shape you. You ended up getting this great educational background that combines science and engineering with health and health governance and health administration. And then, what were some of the jobs that you undertook in your career? And then we'll talk about what you're doing now, what you plan to do, and what you hope to do.
So basically my mark was, I ran around putting in data networks at the College of Engineering, pulling cable and kind of going from proprietary data standards to the internet, and really helping put in the infrastructure, physically putting in the infrastructure of how we built networks. And what was fascinating about that job is I got to run around and interact with all the different departments. So I knew as much as what was going around in the organization as anybody, because whenever they'd want to expand the network, that was something new that was happening in the company. And when I got dragged over to the medical center to sort of do that same kind of work, it had that same kind of effect. And but weirdly, there's politics in technology, and there was this big battle between two types of technology, IBM Token Ring and Ethernet, which is, is absurd today. It was absurd then, but people really felt passionately about it, vendors and everyone. And organizationally, senior leaders fought with each other about territory and turf and things that you just think shouldn't be possible. And so one of my former bosses at the College of Engineering asked me if I wanted to work on this government project that was working on global change research, and did I want to work with them with some of these organizations around the rest of the world to see if we could understand how policy really impacts the community, the human condition, particularly sort of environmental kinds of things. And because everybody was fighting in my own organization at the time, I said, sure, I'll participate in that activity. And so I got to go to Washington, D.C. I got to work with all these interagency groups and some teams at NASA to say, how can we not just do the networking, but how can we share data? Governments around the world were paying millions of dollars to collect and organize information, but they didn't know where it was. They didn't know how to share it. So they were very concerned that people weren't using the information that we're paying millions of dollars for. And so that was happening just as the time the web was coming together, and we were finding indexing technologies and mechanisms to share data. So I got to knock on the doors of all these organizations that had gotten on the internet, but hadn't figured out how to share their data. And I was able to do that with multiple groups, so WHO and United Nations and Centers for Disease Control, as well as NASA and federal agencies. And just as I was about to leave, because I was tasked to do that from the university, I would encourage anybody to work at a university if they get an opportunity. They decided they were going to fire those two individuals who were fighting, because that's really not a super mature organizational thing. And they asked me to come back. And but I'd gotten beyond data networks and really into the information exchange business. And they said, well, what would you need to come back? And I said, well, I would like to be in charge of special projects. And they said, what's that? And I said, well, I'd like it to be my charter. If there's anything broken here, I can go figure it out and, have technology address that. And they said, that sounds like a really good deal. That's all you want? I said, oh, you can pay me some more money and maybe give me a team member and let me hire some interns. And at the end of that journey, I had done these massive re-engineering projects. I was responsible for the revenue cycle and all the weird stuff. So electronic data interchange, telehealth, some of our early patient simulator work, all the stuff that was trying to really innovate and change the work process. And so I really got phenomenal exposure to the whole healthcare ecosystem, all the weird things that we need to do to innovate and grow and to sort of change, and all the barriers. Years before it was common practice, I tried to put barcodes on patients, and the reaction I got of treating people like inventory was visceral. I mean, there was sort of violent, registration people were terrible. They just like, this is horrible, horrible thing to do. But I'd mapped out the medication process, and we knew how dangerous it was, and how busy people were. Today it's standard practice, but as we do these things, it changes. It really changes the organization, but the people are very powerfully concerned about those changes, and they don't all agree. From there, I got tired of big organizational activities, and it was sort of at the end of the dot-com era. And some friends of mine got a bunch of investors, and they had a company that they started in New York City as a classic startup. I was the oldest, I think I was about 40 at the time. I was the oldest person in the company. We had dogs in the office. We had the Russian software development team that we rented the space from was sort of in the next room. It was sort of an ideal classic New York startup focused on supply chain automation, but it was also in gourmet foods, and they had bought a chocolate factory, and they were trying to set it up so you could pick out the chocolates you wanted. And the magic, again, is in the supply chain. It's actually really hard to do customization from a fulfillment perspective and make money. And we ended up doing work with 1-800-Flowers and Godiva, and really trying to take and transfer how you automate activities like that. And that happened right around 9/11. We had just sold the company, just sort of sheer coincidence. And I was looking around to do what I wanted to do next. And I got recruited to come to Central Michigan University and to build a data mining facility with IBM and SAS and Dow Chemical, to go around and do a faculty-based consulting service. And they also wanted to build this brand new building that was sort of state of the art for education for the health professions, and ultimately for a medical school. And so it had a little taste of a bunch of different things I liked, and it was associated with a tech incubator. So I got to sort of get a flair for technology startups. And then we ran into a problem with one of our projects. We did a really wonderful data mining and predictive modeling project where we could predict the daily census on the floors of a hospital just by looking at a handful of data points. It was shockingly good accuracy. And the model never got used. The technology never got used because of the way reimbursement worked, the way the hospital was empty when we started the project, but it took so long to get all the data organized that by the time we got everything finished, hospital filled up again, and the executive team wasn't worried about using analytics to sort of really manage the business. And so a combination of things happened there. I got my doctorate and really was modeling medical errors, really looking at, I had this passion for medical errors all the way along. And an opportunity came up to create a regional health information exchange. And what I decided in healthcare, unlike some of the other industries for manufacturing and and banking and finance, where we could use those predictive modeling tools and analytical tools, the plumbing was bad in healthcare. The data itself was really hard to get at, and it was really difficult to use. And so I kind of raised my hand for some statewide activities to build this regional health information exchange. And that just kind of snowballed into the work that I'm doing now, where I'm still in that kind of plumbing business, and really at the cusp of finally being able to use the data and analytics tools and the AI tools that we were using in other industries, but had been very, very far away from healthcare until it had become digitized and then a lot more interoperable.
So that's kind of fascinating. I mean, I I I was also at that time a token ring and Ethernet, and you're right. There were turf battles, and which is the best tech and things like
Yeah,
that,
yeah,
and it all got sorted out eventually.
yeah. But really, and then we did protocols. We did, the internet protocol. I mean, I honestly, I had a senior executive think that I had personally invented the internet protocol, and he wanted to use IBM's protocols for everything, and I go, no, this is a thing. It's the internet. It's gonna, and that kind of change, I think, became a common thread through my whole career of trying to say, how do we do change management that leads to the creation of new infrastructure that eventually nobody even notices and moves on to the next problem. So that just has been a recurring theme of trying to make trying to make everybody cross that particular chasm in a way that technically and organizationally and sort of from an incentive perspective, the system just kind of gets built and then everybody uses it. Again, nobody notices it unless it breaks.
So, I mean, you do this work with NASA and Washington, and and well, data management, and you get this sort of global view of data, how data exchange, and you get into, and then you decide you get this offer, Central Michigan, and there's a tech incubator there as well. So you get even just all of this additional kind of problem solving and innovation happening. Then you take that statewide, right? But you see all of the challenges going statewide, and you see that healthcare was really behind. Where is healthcare now then? Because so you're the currently serving as the president and CEO of Velatura, right? And you're
Yep.
leading efforts and development implementation operation services across the country, but also you're the executive director of the Michigan Health Information Network Shared Services, right? And where you're looking at improving healthcare, decreasing costs, making valuable data accessible, and so on. So, do you think healthcare is caught up or it's still lagging?
Well, I think healthcare is still lagging. I think it has some opportunities to leapfrog a little bit. Um, but we have a ways to go yet. There's the predominant information exchange mechanism still is the fax machine. I mean, I believe healthcare is the sole industry holding up the sale of faxes. But again, I think we've made tremendous progress. In 2014, President Bush said, well, just before 2014, a couple of years, one of the goals that President Bush had was that by 2014, every American would have access to their medical record. We missed that by quite a lot. Under the Bush administration and under Obama administration and High Tech Act, we funded $37 billion to put electronic medical records in all the health systems. And it took that kind of government push to digitize healthcare in the United States. And now we've had in the 21st Century Cures Act and some recent things, we've had to pass legislation to force people to share data in healthcare, which is odd because we don't see a lot of legislation in other industries to share data. We have disincentives built into the system in the United States to sort of make that happen. We built this model in Michigan for MIHIN, Michigan Health Information Network, when we started that in 2010, and we lined everybody up and then we said, what's the most important thing to share? And they told us. And then when we went and asked them to share the data, they said, oh, that was a really great meeting. Love the multi-voting. All the stakeholders were there. You heard all the voices, but no, we're not going to share our data. And well, what? Why wouldn't you share your data? And they said, well, we don't want to share our data because, well, there might be some privacy or security issues, or could be some competitive issues. And so we don't really want to do that. And that was the hospitals. And then so I went to the health plans, and the health plan says, that's fabulous meeting. Wow, great multi-voting, like got all those priorities down. But we just want you to know we're not going to give you any money. because we only pay for value. And I went, wow, okay. So this job is going to be a little harder than I thought. I thought we were just going to bang up a piece of technology and everybody was going to swap data. And again, no, nobody, everybody, the clinicians, the providers, the state, the payers, they all said this was one of the most important transactions to share, letting everybody know when somebody comes in and out of the hospital. But none of them were going to do it. And we were able to develop what became something we call the use case factory to create incentives where we ended up going to the health plans and saying, well, tell us what value is. And they said, that's a really good question. And then we said, well, would you pay for value? And they said, oh, we definitely would pay for value. And I said, well, that thing we multi-voted on, if that were to work, wouldn't that actually create value? And they went, oh, that'd be hugely value. We just don't believe you're going to be able to do it. I went, oh, oh, okay. Well, you already give all these hospitals millions of dollars as sort of a bonus process. How about if you carve out 15% of those incentives and you give them that money if they participate in all this data sharing? And they went, well, we could do that. And I said, and you can't have the data. I mean, I'll give you some of your data, like just your data, but you can only give those incentives if they share all of their data from all of the other health plans for all the patients. And Blue Cross Blue Shield of Michigan had the insight to do that. And we went from nobody willing to share anything to 93% of all of the possible groups who could share data for that particular use case in 9 months. 9 months, which is like light speed in healthcare. And what we learned, what the health plans learned, is that if we put the right kind of incentive on the table and we had the right kind of technology underpinnings and we'd done all the legal homework to sort of say, this is how it can be done legally, these are all of the steps, things can happen really, really quickly. So to answer your question, I think healthcare is on the cusp. We have been using it, and by the way, I call that a carrot versus a stick. The federal government tends to use sticks. Governments tend to use sticks. You know, you must do such and such to qualify. Whereas on the commercial side, there's an opportunity for carrots. And we saw with e-prescribing, the federal government led with carrots and then kind of followed up with penalties on the back if you weren't doing things for e-prescribing. And they had wild success. They haven't exactly done that with a lot of the interoperability kind of activities, but we figured out if the public sector and the private sector kind of work together where one leads with carrots and the other leads with sticks, and we build a process to say what creates value, then all of a sudden we can get this flywheel going and people do more and more what we call use cases for data sharing. And use cases are sending, notifying when somebody goes to the hospital, notifying here's the lab result, sending immunizations into the immunization registry. We're now at 47 different use cases in the state of Michigan following that same kind of methodology. But what has become really, really important is it's a little bit like a sales quota. Once you get started, you kind of raise the bar the next year to get the money. And the next year, instead of saying send another use case, we've said improve the quality of the data you're sending. Now, anybody who's involved in AI and trying to use data knows that really data quality is really poor, like incredibly poor. And so this process has really allowed us to kind of refine the data and get everybody to raise the bar on the quality and the usability of the information. And what that did is that led us to sort of get calls from other states who'd spent tens of millions of dollars failing in this process because it's a really complicated space. And so that caused us to start Velatura to let Mayan focus on Michigan, but create Velatura to be able to kind of work with the different states. And that's now, in what 13 other states.
So where does Michigan sit in all of the states in the U.S.? I mean, are you the top? Are you number one, number the top five, or top 10? I mean, what do you see?
I would say we're in the top three. Um, Maryland had a really insightful governor about 10 years even before we were formed that used a big stick to sort of get a lot of things moving in Maryland. And then the state of Maryland really continues to invest very, very heavily in Maryland's HIE. And they're called CRISP, and they're a phenomenal group. And they also do work across multiple states. I think they're in about 7 states now. It's a sort of we're two groups that I think have very similar trajectories in the current state. And then there are a couple other state specific HIEs that Arizona is very good. Um, Not to diminish any of the other ones I'm forgetting, but some states have nothing still. So some states are kind of like food deserts for health information.
That's really interesting. I would have thought California. I mean, I'm not American, so I'm just kind of looking from the outside. I thought, somebody like California would be way ahead, or New York or something like that. But
Well, the US is very fragmented in the way we deliver care and the way we approach everything. And so as a consequence, people can do what they want. Organizations can do what they want, and they don't do things in the same way. And so a lot of people use the same electronic health record vendor, and their definition of data sharing is, hey, we'll just get everybody on the same system. It's frighteningly reminiscent of the token ring Ethernet conversation we had. Okay. And it's philosophical. Do you want just one system that's proprietary and owned by a vendor? Or do you want an ecosystem that's built on standards and the ability to continually sort of share and innovate in a way that creates infrastructure that eventually disappears and you just take for granted? And that battle is playing out on a much larger scale for healthcare in the United States and interoperability in the United States. And we know how the story ends. The story ends that eventually you really do land on standards. It's just a matter of how long it takes. And so I think the federal government, the Office of National Coordinator, is doing a phenomenal job in the US of trying to really plot this roadmap in a very hard space where they don't have a lot of sticks, and they haven't yet really organized as many of the potential carrots that they need to sort of really drive what is a huge space. But I think we are incrementally making a lot of progress, but we are not finished. I kind of thought it would go a lot faster. Like I've spent maybe coming up on 14, 15 years on this space. And I kind of thought we'd make more progress before I left it. And I'm now beginning to believe it's really good that we're training interns. It's really good that we're getting an army of new people to tackle this particular problem. But I'm hopeful that it will go the way of the, Apple Talk internet protocol battles that were out there years and years ago.
okay, so yeah, I mean, your state is one of the leaders. I mean, and the work you're doing, you're one of the leaders in America. So out of the 200 plus countries in the world, where does the US sit?
It's interesting. I recently spent some time with one of our priors, Smile Digital Health. It's based out of Toronto. I went to one of their conferences and I sat with some brilliant people who do work in the U.S. and they do work in Canada and some of the other countries. And basically, I think the key important takeaway that I was given that I actually ended up having to acquiesce to, which was nobody should come from the US and try to tell another country how to run their healthcare system. So I think that was probably my biggest takeaway that um, is probably true. Okay. And then I think our model in the US is particularly unique to the US. We spend an unbelievable amount of money on it. Technologically, there are some things that you get when you don't force everybody to one system, and that you do get a lot more innovation, but you get huge waste and duplication of activities. And so I think we're seeing a lot of innovation. I think we're seeing faster adoption outside of the US for some of the standards that are out there. But I think uh, I think over time we're going to see a lot more innovation happen outside the US faster than inside the US in this healthcare space for around the data and its use, mostly because we haven't resolved this conflict around data sharing and sort of making it pervasively available. And so I think um, we have a bigger mess, but we have a lot of very interesting things being tackled. But it's because our system doesn't look at the social side of healthcare near the same way as many other countries do. So I think the opportunity, and we're starting to in the US, we're starting to look at social determinants of health, but we're actually doing it in a very strange way where instead of focusing on feeding people, we're focusing on feeding people so we can reduce the cost of healthcare. And there's things like that that I think mean that the U.S. is probably going to continue to lag, and we're going to spend more on technology, but we are going to keep finding solutions that allow you to not all have to work together as well. And to some degree, there's some of that's useful, but there's an awful lot of that's a waste. And so I think we're going to waste an awful lot more money in the U.S. than we needed to if we all work together.
So the U.S. is not in the. So which countries do you think in the world are in the top 2 or 3?
I don't know. I look at some of the Scandinavian countries. I look at the Denmark countries that have been able to get their arms around their healthcare and do things with their data, but yet have huge respect for privacy and security at the same time, and can build sort of systems. I think they will creep ahead. But to be truly fair, I don't live in those systems. I haven't done years of research tracking them because I've been so consumed with just trying to clean up the mess in my own backyard. So there's a lot I don't know about that space. But
So,
when we compare notes, some things like matching people, okay, like in the US, big challenge is just basic person matching. That doesn't seem to be like the number one problem in a lot of my country counterparts that I talk to.
where does the U.S. sit in terms of spend then? I mean, and then within the U.S. in terms of per capita spend, you know, who's? I guess there's the kind of the raw dollar amount, and where does the U.S. rank amongst other countries? And then there's the per capita amount, and then there's the state-wise kind of efficiencies. Do you think Michigan then is still in the top 3?
Yeah, see, I don't. There's a report that came out that sort of healthcare in Michigan was sort of lower um, than some of the other states by 5-10%, I think it was, but it was based on the rate of costs going up was lower. So it wasn't, hey, look, we're saving all this money and it's going down. It was, hey, it's not getting more expensive as fast. So I don't think, and I certainly don't think you can attribute all of the digitization and the interoperability to immediate lower costs. On the contrary, I think we've seen lots of examples where the costs have gone up when we've added technology and automated. But I think we're increasingly able to meet the demands of consumers to schedule things on their phones and to sort of actually use things they do in all the rest of their life in healthcare. I think the pandemic, we were able to share an awful lot of information where we had infrastructure, and it was a complete disaster where we didn't have infrastructure. I think telehealth, really, really turned on during this. Everybody learned how to do Zoom. Everybody learned how to do some of those things that are game changers in healthcare. But I am sad to say I don't have any concrete evidence that says we're further ahead in Michigan with sort of the bigger picture than anyone else. And I think a lot of that is more we're infrastructure, but it requires all the people systems and the financial systems that layer on top of that to also do change. And that requires incentive changes and policy alignment and funding alignment. And I don't think all of those things have been mobilized yet.
Yeah, I mean, even myself personally, I've seen an increase in sort of a acceptance of telehealth, where I mean, literally, it was like zero or there very
Right?
little, and then it's like everybody, it's just a normal part of your routine now, right?
Yep.
Telehealth is just normal. It's really interesting. So, what are these burgeoning trends that we'll see in the near term? Let's say by 2025, 2026, and then maybe 2030. Do you think the application of AI is going to proliferate more because it's on everybody's radar screen right now? And
I think there's no question that it's going to proliferate. I think, a lot of healthcare is sort of starting in the safe zones for kind of where can we reduce the burden on providers. COVID created what was already a big problem around workforce and provider burnout. It exacerbated all those things. Okay. And so I think there's a real, and we're seeing lots of evidence, there's lots of opportunity to help with documentation, help with a lot of the regulatory kinds of things that force people to do extra work that doesn't really fulfill the taking care of people reason that they got into healthcare. And so I think we're seeing a lot of that. The fact that you can have a Zoom call and it can completely record everything, transcribe everything, and then convert it to the language you want. Those are really tangible things where there were armies of people doing all that work in healthcare before, or the doctor taking a lot of time to do it. So those are going to be very real. I think there's going to be some caution on using it for a lot of the diagnosis activities. We have decades of experience where when technology is against the doctors or against the clinicians, we get a conflict. Okay. So I think it's going to go and start in healthcare in places where the things that the medical community doesn't want to do and is being forced to do as part of regulation or audit or documentation. So I think there's a lot of opportunity in those administrative areas. And to some degree, that's really smart because there's a lot to learn about how we use and apply AI. So start in these safer areas before we move into the categories where they could be transformational, but more dangerous. And so I think the crawl, walk, run philosophy is happening. But I haven't seen the big disruptors yet. And I think what we are ignoring in the US is there's no consumer market for healthcare yet. The telehealth stuff you saw during COVID was the first time we really let people do what they wanted, right? And we found a lot of people didn't want to do telehealth, to be honest, for fair, but a huge number of people who had access to the technology conveniently wanted to do it. Huge numbers of people are going to Chat GPT and asking healthcare questions. Okay. And it's like going to the internet, but a little better. So now we knew they were going to the internet, finding stuff and taking action. They're doing that more now. And the answers are much more sophisticated. And, we've seen where people have been able to train models and tune models to get into that, 95, 97% accuracy, and as good as many clinicians in a lot of situations. So it is possible for there to be a very different approach, but licensure is a political thing as much as it is anything else. And so doctors and doctors and pharmacists fight over who can give immunizations to people. I mean, right? I mean, if you keep that in the back of your mind, physical therapists can do a whole bunch of things, but the laws and states won't let them, right, be reimbursed for doing those kinds of things. I think it's really important that we pay attention to the dynamics of who are the winners and who are the losers, versus what we tend to do is like, hey, this could be good for people. That's not in the US healthcare system, at least, that's not usually the lead in. I mean, that's the storyline, but when you really peel back the layers, there's a lot more under the hood that's sort of preventing people from doing the obvious, what on the surface is an obvious right thing. And then I think the data is bad. And I think people have bias in their data, you know, for lots of reasons. They have bad data. I know this because we provide data and we collect data and broker data. And I think they've been getting data for a while now, since they spent that $37 billion, but I don't think they have been using it. I think they kind of know it's there and they go check it. But with AI, they can kind of like say, here, take all that data we have over there and do whatever magic you're going to do with it. But I don't think they know how poor that data is. And I don't think they've done the hard work for data governance to sort of clean all that up to and including, do they have the right to use the data in certain ways that they now want to do it? And so I think we have a lot of trauma coming in this space. But I also see where folks are taking sort of very safe baby steps. I think they can chip away at the administrative burden and the workforce burden in a really healthy manner. And I think we're seeing that across healthcare.
And yet the diagnostic augmentation, so assistance, so not replacement, maybe
Gotta
transformation.
be careful. We used to say order entry, right? And now we had to change it to order management because it sounded like a much more sophisticated process, but it was basically the same thing of getting the orders into the electronic system. It's the same thing, diagnostic assisted. But they'll do that as much for liability reasons, I think, as we go forward, because you want people to be making the decisions, because we have huge models for suing people about making decisions, and whole infrastructures for that. We don't have that same infrastructure for sort of following up on the AI made me do it.
And yet the AI can give insights into this kind of the rare circumstances, right? Because it'll give you a plethora of possibilities. And
Yeah.
sometimes I think a doctor will miss some of these possibilities because they just are not exposed, right? So
Right.
that's where as an augmentation tool, not a replacement, just to augment.
And I think the augmentation is going to be very real. And I think but I think the problem is not everybody's understanding all these pieces. And so there's people who are kind of like jumping to magic. There's people who are jumping to this very strong Luddite position of it's all terrible. And then I think there's a handful of people who are kind of wading through. We have to sort of be disciplined in how we sort of connect the dots and clean things up. But it's not an overnight panacea for all the problems in the U.S. healthcare system. It really isn't.
Yeah, it's not a panacea, but I'm just thinking it could definitely help. It's like radiologists are overburdened. This could help in reducing the burden. You don't take it out of the equation,
Yeah.
but you just help reduce the burden, right?
100%. And again, we get questions of, okay, well, the AI that I used in my image analysis, it didn't flag that, so I didn't see it. Who's at fault when that whole thing goes to court? And often my AI does that. Those kinds of things we have to work through, and they'll take us a while.
Yeah, and then you're seeing. I wish we had a half hour now, but I have another interview coming up.
No worries.
And but you have this whole consumer side, right? I mean, I use my watch every day, and it's giving me all sorts of health related information, right? And I love that information, and it's just getting better. So,
I do believe, I mean, at the end of the day, there's sort of a common thread that you're responsible for your own health, right? And yet, in a lot of our, certainly US culture, you went to a doctor and they told you what to do. And I think that opportunity is shifting. It's been shifting for a while, but I think as you can have your own glucose, monitor at real
Right.
time, right? As you can, eat something and look on your phone and say, oh wow, that's probably not the right order for me to eat that, right? I mean, that kind of personal feedback combined with the ability, and this is something the US has done a really good job of saying you have access to your record. Every health plan in the United States was required to publish an API to give every single beneficiary access to their information.
Right.
Shockingly few people do it. Okay, but I think this is the big opportunity for AI, is that when people allow those little AI services to connect to all this information that everybody's now being forced to publish, I think it's going to come up with some new challenges that people will bring into their doctor. And I think the opportunity is, on a bad side, is if there's a big disconnect there between how the medical profession delivers those services and what people can kind of glean from themselves, aided by AI. I think there's going to be an erosion of trust and erosion of value there that will happen pretty substantially. Kind of like travel agents, right? We used to go to travel agents to sort of help figure our way out. And there's still a role for certain kinds of folks for travel agents, but there's an awful lot of it you can kind of manage and do yourself. I think when that gap gets too wide, people are going to complain, and I think that's the danger in the healthcare system, is they've got to manage that gap right now.
There's this new edition of AI coming up, right? And it's kind of like has some planning and memory, and it runs agents.
Yep.
And
Yep.
I even did some book forwards over the last decade where I predicted where we are today,
Yep.
where we're going to be in a year's time, where you just, it's preventative, it alerts you, it runs all of these little agents for you. You don't even have to micromanage this stuff. It just
That's right.
does it.
That's right. Yeah. And but again, we have licensure and we have payment, right? And so I think what you'll see is those individuals who are able financially and technically and from a numeracy literacy perspective, I think they're going to take control of their own health.
Yeah,
They're
that's
not going to take control of their own health in the way that they're going to take control. They're going to feed all their information into sort of this new infrastructure around them. And what will happen in the US is, if that starts to work really well, if we change the payment model,
right.
payment, and I can tell you this from our own use case factory, payment drives everything in the United States. I mean, it's a business. And so if the financial incentives shift to really support that, then I think you'll see massive change. And I know it can happen very quickly because we've seen evidence of that in our own scenarios. So there could be a lot of change. The problem will be is that doesn't always work for these tertiary quaternary situations
Right.
that the US is actually really, really good at in the world. Okay. And those are very substantial cost structures. Now, whether you need two of them across the street from each other is a bit of an issue, right? Because we have two such facilities that within walking distance in many cities. But I think that will be, now we've got this gap where, yeah, AI is not really helping us with that. Our own personal management isn't helping us with that. But this requires an awful lot of infrastructure. And so unless that infrastructure and the cost to service it gets recovered some other way, it will be a real negative impact to the system if things change too quickly.
So Tim, I've got about a minute left. So we're gonna have to do some follow-ups. There's just so many different areas we can slice and dice this. And you are doing so much great work. So last question: what are your recommendations to the audience?
Um, my wife and I wrote a paper a while back. We called it the lug nut theory, and the whole concept of lug nut theory is, for anyone who's ever changed a tire, right? When you take the tire off and you put it back on, first you got to have a tire that actually fits your car, right? Or it could do damage to the whole engine right after you drive it. You don't notice, you can still move. But when you put that tire on, you put the lug nuts on, and you put them on in an order that allows to make sure each lug nut gets snug and the tire isn't woppy jawed. A lot of what we're talking about with technology is a lot like putting those lug nuts on in the right order and making sure they get tightened down versus taking one lug nut and just ratcheting that baby all the way down. So I think what my key message is to really think about picking out the right tires for your car, okay? Because it does matter. But then when you put it on, recognize that it's not just one dimension. You've got the technology piece, you got the regulation piece, you got the money piece, you have the organization piece, and you also have the efficacy piece. Now, a lot of times as technologists, we get our tech bolt, we ratchet that thing down, and that's the magic answer. We haven't even done anything with the efficacy piece to really decide if it's a value, and we haven't done this crisscross to make sure we've got it snug. That concept of making sure you kind of attack it from those different dimensions is really important, because you're trying to put the tire on. You're not really trying to like put a one lug nut.
Well, I have an interview coming up with Stephen Shea next week, so or the week after. I'll drill into this, all of the lug nuts balance, as you mentioned, right? Because he's trying to address it, right, with population.
It's a tough thing, and you gotta put all the pieces together.
So thank you again, and just loved all of the insights and all of the sharing that you've done, and we've got to do more. So thank you again for coming in.
Look forward to interacting next time.
Thank you for listening to the Brand Called You videocast and podcast, a platform that brings you knowledge, experience, and wisdom of hundreds of successful individuals from around the world. Do visit our website www.tbcy.in to watch and listen to the stories of many more individuals. You can also follow us on YouTube, Facebook, Instagram, and Twitter. Just search for the Brand Called You.